here some of the data points that I took from that article. Though the COVID-19 response to date has been focused primarily on containing the spread and preventing mortality, the pandemic has the potential to create a secondary crisis of psychological distress and mental health system spillover. Now, I can tell you from my perspective, both in my private practice as well as teaching full-time and working with lots and lots of students across my coursework and field work, there's nothing potential about it. People are under tremendous psychological distress and their mental health is being affected. And I'm seeing that across my teaching life, my clinical practice life, and my personal life. So so I agree with that statement, but I would say it's more than a potential, or to be fair, the Journal of American Psychiatric Nurses Association, this was written earlier in 2020, so I don't think we even fully realize, and perhaps we even now, at the time of this recording, have really fully realized the behavioral health impact of COVID. All right, so prolonged exposure to stressful environments. This is now kind of turning the article kind of turns its attention to the hospital setting. Prolonged exposure to stressful environments, invasive procedures, and the perception of threats in an intensive care unit, in ICU in a hospital, can be experienced as traumatic, leading to long-term psychological harm. So if you've ever worked in an ICU, and I have now many years ago, got to work on an ICU as a social worker for a couple of years, which was intense, but a very wonderful experience in terms of social work experience. But there's no question that historically patients find the ICU to be a stressful environment, and families of patients who are in the ICU, understandably so. And now what we see, because often people are faced to one extent or another with invasive procedures, surgery, anesthesia, and many people in the ICU are facing very directly their own mortality, and of course, their families are facing the mortality of a loved one. And so what we find in the era of COVID now is that healthcare workers are, while the ICU can be one of the more stressful places to work within a hospital or any healthcare setting, now they have potentially the same or somewhat of the same mortality threat because of COVID. So I added here that the healthcare workers, as well as patient and families, are susceptible to traumatic exposure, and particularly for the healthcare workers, prolonged exposure, where like with military and first responders, it's not necessarily one particular event that causes a trauma-related injury or health problem for them, but sometimes it's the prolonged exposure to intense stress and prolonged exposure to life-threatening stimuli, or potentially life-threatening stimuli. The other thing that is happening, again, I know you guys are aware of this, and it's why I selected and you see that in the title slide. You see the picture that I selected for it specifically reflects this, is that families and patients can be even under more stress because they can't see their loved ones, at least face to face, and sometimes they can't see them at all, depending on the digital circumstances and their access to internet and devices. So people can have loved ones in the hospital who are faced with mortality, either related to or not related to COVID. But even if it's not related to COVID, visitation is limited in many places. There is no visitation, Some places offer virtual visitation, but not everyone has access to that, and some places don't offer virtual visitation either. So we have the added potentially traumatic stress of the limitation of visitation of loved ones. And again, we can see that fall back on the healthcare workers as well. Imagine a nurse or doctor or social worker or other healthcare worker having to hold a tablet or phone device for a patient who's dying so they can say goodbye to their families, and how difficult that must be to do that in person, and how much more potentially difficult and potentially traumatic that can be for everyone, including the healthcare worker, when they can't even do that in person. They can't have that closure in person. Rapid influx of patients seeking COVID-19 treatment has the potential to displace mental health beds and treatment capabilities in inpatient settings. We've certainly seen, perhaps you've picked up some news articles. I've certainly read a few where people who have COVID or a non-directly COVID-related emergency or urgent healthcare condition, they can't get. They can get to the hospital, but the hospital doesn't have the equipment or the beds that they need, and in some cases, people are dying directly as a result of the hospital not having the supplies and the personnel needed to treat them. And so we can imagine that that is likely, even if you haven't, or I haven't seen a news story specifically on this, displaced mental health beds is certainly, look, if people are displaced who are coming in for intensive care unit level of medical need, we can, I think, pretty easily imagine that mental health beds or substance detox beds may be affected as well. So this increasingly challenge how to manage and treat acute psychiatric crises in the emergency rooms, and how to ensure safety and care continuity of currently hospitalized psychiatric patients. So, I can attest to the latter of that. To the former of that statement. That's, to me, that's pretty heavy when you have, in other words, it's a heavy thing to have the responsibility, not heavy in a bad way, but heavy in a, it's a responsibility that I take, and I know all of you will take very seriously. You, as an LCSWC, you have the legal authority to, at least in Maryland, to have someone taken on an involuntary basis to an emergency room for an emergency evaluation. And that's a heavy responsibility outside of COVID. And now, when you think about somebody who may be in crisis, maybe potentially unsafe for themselves or those around them, and having to make that ethical decision, is their safety, their own safety or other safety in jeopardy to the point where you need to make that decision? Well, now you have to factor in the potential COVID exposure in an emergency room or in a hospital. So, so it kind of just adds this additional kind of importance and stress dynamic to those kind of decisions, whether to hospitalize somebody, discharge decisions when you have an outbreak in a hospital and you have a hospital wing of patients, receiving inpatient psychiatric or substance detoxification treatment, and how that might affect one's decision making about when and where to discharge someone to. So lots of really important considerations and challenges coming up directly from COVID, as pointed out in this article from the Journal of American Psychiatric Nurses. All right, so some more data points from this article. Social distancing measures increases risk for loneliness, isolation, and anxiety. It's likely you guys have seen that firsthand. I certainly have, let alone on the news and in the media. A high potential for individuals with pre-existing mental illness to experience exacerbation of symptoms or impairment in functional status due to increased stress. Absolutely see that in my practice. A significant amount of that in my clinical practice, and just from working with you guys as students, both in the classroom and in the field, I have a sense of the impact it's had on you guys as students as well. Being isolated at home may increase family or financial pressures as the economic fallout of the outbreak worsens, for sure. Job jeopardy, job insecurity, something just hearing really quite a bit in my clinical practice, and in my and seeing that directly in my personal life as well. Individuals may face unemployment, housing instability, food insecurity, while caregiving responsibilities for children and other family members intensify. The stress and that's falling upon families, particularly single-parent households, with trying to provide online, trying to support online education at home while having to work themselves, either having to leave the house to work, or having to work at home and be online without interruption. In other words, an employer requiring that employee is online all the time, logged in and on camera. Even if they're able to work from home, it can still be quite stressful. And I've seen people really push to the brink of their coping, and beyond the brink of their coping, this very topic here. And it's certainly things like these other social concerns of housing and employment and food access, let alone food nutrition, all are intensified, as they point out here by I think they accurately point out here in the article. Those who experience trauma or violence in their intimate partner and family relationships, including psychological trauma, may be at increased risk for victimization. Again, this is probably something that you've likely seen in the news media and other media outlets. There was another PBS piece that I watched from around the same time that the mental health piece came out, where they were looking at the piece looked into two corresponding pieces of data. So on the one hand, when they looked at national level data of reports of child abuse, right now I'm just speaking directly about of abuse and neglect to children, for the sake of the point here for the moment. So the PBS piece specifically looked at and spoke with people at the that look at child abuse reporting data at a national level, and then they also were looking at data from, again, national level data that comes from hospitals across the country on child and adolescent presentations where certain types of injuries, certain types of patient complaints are highly correlated with abuse or neglect. You take those two pieces of data, and here's what the reporters found in the news piece is that the number of reports of child abuse and neglect at a national level, and this was kind of summertime of 2020, were drastically down. But the number of diagnostic, just looking at diagnostic codes, the number of child and adolescent emergency room presentations that had a diagnostic code that tend to be highly correlated with abuse and neglect were way up. Okay, so evidence of child abuse and neglect from the emergency room perspective significantly increased, while the number of reporting at a national level, at least at that slice of time, was significantly decreased. And I think that, for me anyway, that kind of said everything we need to know about this idea of what's happening with people who are vulnerable to physical, sexual, and psychological victimization. They're just much more at risk because of support systems such as school social workers for children that can sometimes be a line of defense or at least a line of detection are not in place.